money. Mental health practitioners at Kaiser Permanente in California and Hawaii, within the National Union of Healthcare Workers, are in their second month of striking for increased mental health staffing to meet their patients' needs. Right now, Kaiser patients have to wait months to get an appointment with a mental health provider. And at the same time, Kaiser is being investigated by the Department of Justice for squeezing $1 billion in excess payments from Medicare Advantage by adding irrelevant diagnoses to medical charts, including for major depression, to increase their payments from the Medicare Trust Fund. In this case, Kaiser is clearly receiving high payments for patients that they claim have major depression, but not using those payments to hire mental health providers to provide the treatment they are being paid for. Tragically, seniors with Medicare Advantage plans at Kaiser have even taken their own lives while waiting for mental health treatment. So these mental health providers are on strike, fighting to put their patients over Kaiser's profits. The previous administration exacerbated these problems in Medicare Advantage with the establishment of the Medicare Direct Contracting Program, which allows private organizations, often Medicare Advantage insurers and investment firms, to administer their Medicare benefits. While my colleagues and I urged the administration to stop this program to ensure comprehensive care, CMS only recently announced that it will begin to transition away from the program. It's a step in the right direction, but there's much more to do to protect Medicare. It is clear that private interests are using our healthcare system to squeeze out all the profits that they can, and that Medicare for All is an overarching antidote to our country's healthcare problems. I'm really thrilled to be joined by our panelists to discuss why it's critical to remove profit from healthcare to achieve a truly equitable healthcare system. And I'm also thrilled to be joined by my co-lead of the Medicare for All bill, Representative Debbie Dingell, who has been a real champion on this issue and on the committee of record, the Energy and Commerce Committee. Debbie?
Thanks, Pramila, and thank you for all the hard work that you do on this. And I want to thank all of our speakers today. I'm going to tell you right now that I've never been more passionate about Medicare for All than I am right now. There was a poll last week, and I meant to pull it up before we spoke, that over 90% of the American people are unhappy with the healthcare system right now. They are not getting the care that they need. We're in the midst of an ongoing pandemic that has exposed and exploited the fundamental flaws of our existing healthcare system. And as I just said to you, the polling is just consistently showing that people are hurting and they need more help. When you're sick, you need to be able to go to the doctor when you're sick, afford your medicine, and get the care that you need. And too many Americans are not getting that right now. We've got to get this done. And I'll make this case every single day. You know, it's obviously not likely before the end of the year, but when we start the new year, we need to be making the case very loud and very clear as we go in to the presidential election, because people aren't happy. They're not getting the care that they need. And a healthcare system that ties coverage to employment will always leave patients vulnerable, certainly during a pandemic, as we have just seen. We watched millions of Americans lose their jobs, and as they lost those jobs, they lost their healthcare coverage at a time when everyone needed to have that guaranteed coverage. We saw a rise in preventable deaths, as Pramila was just speaking about, because people were reluctant to pursue the healthcare that they needed. And by the way, my mother was just in intensive care and then in rehab and got COVID. COVID is still very real. And when a senior gets it in particular, or someone with underlying conditions, it's a real scary thing. And too many people can't afford to go to the doctor, get to the doctor that they need, get the help that they need. And we saw corporations pad their bottom line at a time when thousands of Americans per day were dying of the coronavirus, as Pramila was talking about, while others just couldn't get the treatment that they need. It's just unacceptable. It's flat out wrong, and Medicare for All would put a stop to it. I believe that we have learned that we cannot back down when it comes to universal health care. We are one of the few, and I actually think we're one of the only industrialized countries in the world without universal health care that does not guarantee its citizens that when they're sick, they can go to a doctor. We should be more ashamed of that fact than the policies of the ones that we need to correct it. We spend twice as much per person compared to countries with systems like Medicare for All, and we still have 27 million people without insurance. And we have worst outcomes, including low life expectancy and higher infant mortality rates. The only people that are benefiting and the people who don't want us to improve the systems are those that are profiting from while Americans suffer. So I look forward to hearing from our experts today on the extent of private profiteering in our healthcare system and discussing how we can shine a better light on it so people know what's happening and how we can stop corporations from profiting at the expense of individuals who should be able to get the medical care that they need. Thank you.
Thank you so much, Debbie. Now we're going to introduce our panelists and hear about their work in the space before we jump into questions. And so with that, I want to welcome our first panelist, Dr. Susan Rogers. Dr. Rogers is the president of Physicians for a National Health Program. She recently retired from Stroger Hospital of Cook County, Illinois, and she's an assistant professor of medicine at Rush University. She's also a fellow of the American College of Physicians and a member of the National Medical Association. Dr. Rogers, thank you for being with us, and the floor is yours. I think you're muted, Dr. Rogers. There you go.
Thank you so much for inviting me to speak today. And like you said, I am the president of Physicians for a National Health Program, which is a national organization of over 24,000 doctors advocating for Medicare for all. Now, direct contracting, which has been renamed the ACO REACH program, which will become enacted in 2023, is an effort to completely privatize Medicare. Many beneficiaries, like myself, chose to enroll in traditional Medicare and not participate in privatized Medicare Advantage. But many are now being handed over to for-profit private entities in the ACO REACH program without even being asked. And these entities, fueled by unlimited investments from venture capitalists and private equity, will always prioritize, as dictated by their mission, their own profits above the health of patients. And most ACOs are controlled by many of these investors. Now, there's been much discussion about why the costs of healthcare continue to increase. Within Medicare, traditional Medicare's fee-for-service payment system has been called the problem, despite its incredible history of efficiency, long history of improving healthcare among seniors, and its low administrative overhead of less than 2%. There are things that need to be improved within traditional Medicare, but the system on which it functions works. Now, there is absolutely no data that fee-for-service increases costs by creating a system of overuse. But what we have created and built over the last 50 years is a healthcare system that includes in its core structure private and for-profit entities. We now have private and public employers that pay private healthcare insurers to pay for our care via private corporate entities, all funded by our tax dollars and all wanting their piece of the pie. This structure is flawed because there is a direct conflict of interest between physicians whose mission it is to care for patients and improve their health, and the payers whose mission it is to make profits. As history has shown, the recently announced REACH program will waste millions more dollars by letting fraudulent actors continue to participate. Last year, Centene was ordered to repay the Department of Veteran Affairs almost $100 million for inflated and duplicate claims. Medicaid plans have been cheated out of hundreds of millions of dollars, resulting in large settlements. And the Office of the Inspector General has found widespread inappropriate denials of services and payment within Medicare, where delays not only increase the administrative burden placed on physicians and patients, but put billions of taxpayer dollars into the coffers of these for-profit entities. There are many, many more similar examples. And their goal to address inequities is insincere with their lack of including many physicians who practice in zip codes dominated by poor people included in ACOs, along with the removal of physicians within ACOs labeled inefficient because they care for costly poor people. This continued expansion of privatization will not improve patient access or outcomes. We can see clearly how deadly privatization can be, so it is up to Congress and the Biden administration to stop this program. And at PNHP, we call for an immediate end to the ACO REACH program and ending value-based payment systems. We support Medicare for all.
Thank you very much for that, Doctor. You were wonderful, Dr. Rogers. Next, we welcome Eileen O'Grady, Healthcare Research and Campaign Director for the Private Equity Stakeholder Project, a nonprofit organization serving as a watchdog of the private equity industry. She has written extensively on issues related to private equity investments in various aspects of the U.S. healthcare system, and she's been featured in the New York Times, the Wall Street Journal, Bloomberg, ProPublica, the Los Angeles Times, and many others, and I've learned a lot from her. Eileen, thanks. You're on.
Thanks so much. As the Congresswoman said, I am Research Director of Healthcare at Private Equity Stakeholder Project. As a watchdog organization dedicated to understanding the impacts of private equity and our economy, our mission is to empower communities, working families, and others impacted by private equity investments. And because the private equity industry is so huge, those impacts are widely felt, even if we don't always recognize when a private equity firm is behind them. Today, private equity firms control about $7.5 trillion globally, and that grows every year. In the first half of last year, they had their busiest 6 months ever, announcing over 6,000 deals worth over $500 billion. And healthcare, alongside tech, is the biggest target for private equity investment these days and has grown tremendously over the last decade or so. In 2020, PE firms spent almost $100 billion on healthcare deals, which was a 71% surge in deal value compared to 6 years prior. And we expect the surge to continue. There's been a frenzy of consolidation and investment, particularly in physician services like orthopedics, OB-GYN, gastroenterology, radiology. But private equity has been investing in virtually every aspect of healthcare: nursing homes, safety net hospitals, home healthcare, behavioral health, travel nursing agencies, dentistry, pharma, medical devices, prison and jail health, medical billing and debt collection, you name it. They're even beginning to find their way into nonprofit healthcare by creating hospital management companies that essentially run and operate nonprofit and community hospitals. And those arrangements and the PE firms behind them operate largely in the shadows. So knowing the private equity business model and its track record that we've seen so far in healthcare, this explosion of healthcare buyouts is very troubling. Private equity firms, regardless of what industry they're investing in, are typically trying to double or triple their investment over a pretty short time horizon. And because of that, firms are laser focused on increasing the cash flow at the companies they own, which in many cases at healthcare companies means cutting staff, reducing less profitable services like hospital labor and delivery services, for example, or finding other ways to strip assets out of healthcare providers to generate those high returns. And from private equity industry's perspective, it's working. A 2019 industry report noted that in the current economic cycle, private equity healthcare deals have returned $2.2 for every $1 of invested capital, which is a higher multiple than any other sector. But between asset stripping and finding ways to massively cut costs, these profit-seeking tactics can have profound impacts on patient care. You can think of private equity as for-profit healthcare on steroids. And because of their limited liability and the opaque nature of the industry, it's incredibly hard to ensure compliance and hold firms accountable. It's therefore critical for policymakers to pass legislation and for regulators to propose rules that, at a baseline, increase transparency and accountability for private equity investments in healthcare. And Representative Jayapal's Healthcare Ownership Transparency Act, introduced earlier this year, is an excellent first step in building the groundwork for reining in some private equity's most harmful and extractive practices in rating healthcare infrastructure. And I'll stop there for now, but I'm looking forward to hearing your questions. Thank you.
Thank you so much, Eileen. It's really stunning, and your research has been so helpful in articulating the problem and making it visible. Our next panelist is Mr. Egan Kemp, who is a healthcare policy advocate at Public Citizen, a nonprofit consumer advocacy organization with over 500,000 members and supporters nationwide. Mr. Kemp is an expert in healthcare policy, and he also served in the U.S. Government Accountability Office as a senior policy analyst. Welcome, Egan.
Thanks so much for having me. And thanks so much to both Representatives Dingell and Jayapal for convening this important discussion. As you mentioned, I worked at GAO for almost a decade before coming to Public Citizen. And I can safely say, after seeing sort of across those 15 years, that profit is destroying healthcare in the US, and it's only getting worse with each passing year, and that Medicare for all is the best solution. As the previous panelists made clear, greed and profit are undermining all aspects of our healthcare system. I want to focus my comments on the growing body of evidence showing how Medicare Advantage is hurting seniors, threatening traditional Medicare, and funneling taxpayer dollars directly into insurance company profits. For example, when Kaiser Family Foundation analyzed data from 2019, they found that the federal government was paying over $300 more per senior for beneficiaries enrolled in Medicare Advantage than for those in traditional Medicare. And between 2010 and 2019, Medicare Advantage overpaid MA plans by more than $106 billion because of the way private plans charge by upcoding for patients. And insurers are getting increasingly effective at gaming this system, as nearly 1/3 of that $106 billion came in the last 2 years of their analysis, 2018 and 2019. A further study found that excess spending is likely to balloon up to $600 billion between 2023 and 2031 if CMS keeps its current coding adjustments in place. And because Medicare Advantage plans target seniors that are typically healthier and younger than traditional Medicare enrollees, there's no reason to think that these folks couldn't be covered more efficiently in the much more efficient traditional Medicare program. And this excess spending is happening while Medicare Advantage plans are denying seniors needed care. A couple folks have referenced the HHS OIG report that found that Medicare Advantage plans among the largest Medicare Advantage plans, they denied nearly 15% of denials that would have likely been allowed under the traditional Medicare program if that person had been enrolled. They met sort of the most important standards for medically necessary care. These denials, even though some eventually get overturned, delay and may even prevent seniors from getting the necessary care in a timely manner. It also burdens providers like Dr. Rogers, who are just trying to do what's right for their patients. In addition, the GAO has also done a couple of important studies. One was looking at beneficiaries in the last year of their lives. They were significantly more likely to disenroll from their Medicare Advantage plans and enroll in traditional Medicare. This meant that instead of being able to focus on time with their loved ones in their final weeks and months, seniors were having a hard enough time getting the care they need through Medicare Advantage that they would go through the administrative hassle of switching back to traditional Medicare. It means that Medicare Advantage are keeping seniors on their rolls while they're profitable, and then sticking the American people with the bill when they actually need care. This is not the first such damning report from GAO. They previously found that CMS needs to do a much better job overseeing Medicare Advantage plans because sick seniors are being pushed off Medicare Advantage and back into traditional Medicare. Last thing seniors need when they're experiencing a chronic or acute illness is to have to switch plans. And then even when they switch plans, they may face challenges as they're trying to navigate all sorts of new doctors or anything like that. We advocates, Congress, the administration must do more to pressure these companies through legislation, regulation, and even excoriation. We must hold actors accountable in the meantime, but the reality is the best solution to this problem is Medicare for all. And Representatives Jayapal and Dingell are obviously leaders in that fight, but we thank all members of the Medicare for All Caucus for their continued efforts. Finally, I just want to close by highlighting a couple reports that we've got coming out. We recently put out a report on nursing homes, which folks will find in their meeting materials, that tested the comprehensiveness of ownership data currently being published by the federal government and honed in on some of those PE-backed nursing homes and some concerning findings therein. We also are finishing up a report on case studies of private equity abuses in healthcare and publishing a series of reports in collaboration with People's Actions on healthcare denials and the havoc they wreak for patients, providers, and the healthcare system more broadly. Looking forward to taking folks' questions. Thank you.
Thank you, Mr. Kemp, for those remarks, and I cannot wait to read those reports. Yours are always excellent. Next, we welcome Dr. Don Berwick. Dr. Berwick is President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, Lecturer of Healthcare Policy at Harvard Medical School. And his real experience also, like a lot of experience, I didn't say right, but I've known him since he was a former administrator of the Centers for Medicare and Medicaid Services. Welcome, Dr. Berwick.
Thank you, Representative Dingell and Representative Jayapal. It's just an honor to join you, and thank you for your leadership. Half of Medicare beneficiaries are covered by Medicare Advantage, where public funding is filtered through private hands. That takes a massive toll. My colleague, Rick Gilfillan, and I have labeled one form of that toll as the MA money machine. That's a no-lose, guaranteed moneymaker that subsidizes MA plans. I'm going to give you a couple of real examples from the real world of how, in part, that money machine works. First, a doctor in a group practice that was purchased by an aggressive for-profit insurance company notices that all at once, every single patient he has with atrial fibrillation has a new diagnostic code, hypercoagulable state. Most people with AF have that. Nothing has changed or should change about their care, but now the HCC risk score of every patient has gone up by 20%, paying the plan $2,500 more per person per year. Second case, an organization heavily invested in MA has its doctors screen every patient for homocystinemia. That's a biochemical diagnosis that the U.S. Preventive Services Task Force does not recommend screening for, but it adds 20% to the HCC risk score, $2,500 per person per year. Third case, an insurer rewards doctors for doing ultrasound screening of the carotid arteries of asymptomatic patients. That's a test that the U.S. Preventive Services Task Force recommends against. The HCC risk score goes up by 30%. That's $3,600 per person per year. A fourth case, Medicare Advantage insurers hire Signify, that's the largest coding company in the United States, to send nurses into patients' homes to do ultrasounds to find evidence of minimal changes in leg arteries, for which they add the diagnosis of peripheral vascular disease to anyone with any narrowing at all. HCC risk scores go up 30%, that's $3,600 per person per year. In none of these cases is care management changed a bit. The atrial fibrillation patients are already being treated. The homocystinemia patients do not need treatment, and minimal carotid stenosis should not be treated. But the more codes the plan or the doctor finds, the more payments they get. That's a money machine. That isn't care, it isn't quality, it's just a diagnosis and coding game. It's worth tens of billions of dollars to MA plans every year, and it adds no value at all to patient care. That's one reason, by the way, this month, why Aetna CVS, the largest national Medicare Advantage insurer, offered $8 billion to buy Signify, which is mainly a coding company. The plans know it, the consultants they hire to upcode know it, many physicians know it, MedPAC knows it, and yet to date, Congress and CMS have done little to stop that bleeding. In fact, CMS this year in its physician payment rules said MA payments would increase by 8.5%. Almost half of that is due to coding, worsening the problem. The consequences are and will be an existential threat to traditional Medicare and to the ACO program, continuing worsening of the financial state of the trust funds and demoralization of clinicians who know how cynical this game is. What do patients get? Well, they get locked into MA because those new diagnoses are now pre-existing conditions that make it nearly impossible for them to get Medicare supplemental plans that they need to return to traditional Medicare if they would want to do that. And I'm in traditional Medicare. I'm not saying that no MA plans add value. Some, such as many members of the Alliance for Community Health Plans, for example, and much of the work of Kaiser Foundation Health Plans, to be honest, have a track record of innovation and care and really try to focus on patients' needs, but even they have to play the coding game to survive. In aggregate, as you've heard, this and other games in Medicare Advantage are estimated to add over $600 billion a year, $600 billion to Medicare's bill over the next 8 years. Congress and CMS can stop that snowballing MA subsidy, and they should. Thank you very much.
Thank you so much, Don. You have been such a champion, and it's been so great to work with you because you actually know what's happening at Medicare. You ran it. You know exactly what's happening in the gaming of the system. Finally, we have Kathy Kennedy. Ms. Kennedy is the president of the California Nurses Association and vice president of National Nurses United. National Nurses United has been a great partner with us on Medicare for All and is the largest union of registered nurses with over 175,000 members nationwide. Thank you and welcome, Ms. Kennedy.
Thank you very much for that introduction. And I want to thank the Medicare for All Caucus for hosting this very important conversation. You know, I've been a registered nurse for more than 40 years, and I'm still at the bedside, and I work in the neonatal intensive care unit at a hospital in Roseville, California. As nurses and patient advocates, NNU members witness the profiteering of the hospital industry and the insurance industry every day at work, and we see its horrible impact on our patients. Our healthcare system is deeply broken because of the ability of the healthcare companies to profit off of patients and because government has failed to guarantee healthcare as a basic human right, as everyone has spoken about this morning or this afternoon. The U.S. spends more per person on healthcare than any other country in the world, including countries that guarantee healthcare to their people as a right. Yet our current system regularly deprives patients of necessary healthcare and has worse outcomes than other wealthy nations in key indicators such as lifespan, infant mortality, and chronic disease burden, such as Congresswoman Dingell had mentioned earlier. While healthcare has become increasingly unaffordable for patients, the coffers of the corporate healthcare industries have been getting larger. 2019 was the most profitable year for the hospital industry ever, with a total net income of more than $100 billion. 2020, the first year of the COVID-19 pandemic, was the second most profitable year for the hospital industry, with a total net income of almost $92 billion in the US alone. And the health insurance industry raked in $31 billion in profits in 2020, which was a 33% increase over the previous year. To add insult to injury, the CEOs of some of the biggest hospital and health insurance companies reported total compensation of more than $19 million last year. While our hospital employers were raking in huge profits, nurses were working without the critical personal protective equipment and critical medical supplies that we needed to do our jobs safely in the midst of the pandemic. Hospital corporations could have been purchasing critical medical supplies, and they could have been spending this money on N95s and other types of respirators that we desperately needed to protect COVID exposure to healthcare workers. And they could have been hiring more bedside nurses to care for our patients, but instead they line their own pockets. Additionally, hospitals received billions of dollars in financial aid from the federal government, but as nurses, we didn't see the result of that money in our facilities. Taking profits from people's illnesses and injury is not a problem solely limited to hospitals that are designated by the IRS as for-profit. So-called nonprofit hospitals behave in similar ways. Both for-profit and nonprofit hospitals price gouge and both cherry pick the wealthiest patients. They all understaff to the great detriment of safe patient care. You know, and as a nurse, a healthcare system that prioritizes profit over patients is an immoral one. It really conflicts with the nurse's duty to our patients. But thankfully, the solution to this problem is extremely clear. Medicare for All would prevent this profiteering while ensuring that all patients are guaranteed comprehensive, high-quality healthcare. Our healthcare dollars would be going towards care, not corporate profit-making. So I really want to thank the Congressional Medicare for All Caucus for having NNU here today, and we really look forward to working with all of you to guarantee that healthcare as a human right for everyone. looking forward to your questions. Thanks.
Thank you so much, Kathy. And we do have a few of our members on, so I want to make sure that we go straight to member questions or comments. And so other members other than Debbie and I, we want to make sure to get your voices in. So if you do have a question or a comment, please go ahead and just raise your hand in the chat, and I'll be happy to call on you. And I think I see Shelley Pingree, perhaps. I'm not sure. Sorry, I'm not sure if that is the case or not. So if we don't have questions, then Debbie, do you want to ask the first question, and we'll just wait for our colleagues to.
Absolutely. Let me start with Dr. Rogers. Based on your experience as a physician, can you illustrate how the profit motives of healthcare companies have impacted patients' ability to access quality care and what's happening to them? I could even give you a few stories from just having lived in the hospital with my mother and rehab for the last 5 weeks, but you're the expert. Dr. Rogers, your mic's not on. You're muted.
I'm sorry.
No, no.
Thank you for that question. And I think that this is an issue that I think any practicing physician has multiple stories that illustrate the issue. But one situation I'd like to describe is for over almost about 15 years, I worked at one of the neighborhood clinics funded by Cook County Hospital when I was attending at Cook County Hospital in Chicago. And across the street from the clinic, there were two senior citizen resident buildings, and they had many, many patients, many of whom came to the clinic for their care. One day I noticed a patient of mine came in for a routine appointment, and she had a tote bag with the emblem of a private insurance company on it. And I didn't think anything of it until the third patient came in with the exact same bag. And I asked her, I said, where are all these bags coming from? And she told me, oh, well, they were all at the building and we all signed up for care with them. And what had happened was Medicare Advantage had come to the senior citizen building, taken these patients who previously were all in traditional Medicare, and they tricked them, essentially tricked them, because they didn't know what had happened, into signing up with Medicare Advantage. The implication of that was now, despite them living in a senior building, having some issues with mobility and transportation and finances, they lived right across from me. They were not able to see me anymore because I was not in their network. They could not get their medications from the clinic where they used to come because it was not in their network. So overnight, these patients lost their access to care, unknowing to them, because they were fast talked and essentially tricked into signing up with Medicare Advantage. And I know that that's a scenario that has not just happened to me, but it has happened to multiple physicians, multiple seniors who live in senior residential buildings. And it's a travesty that these insurance companies come in, knowingly trick patients into getting into their program so that they can receive the money for their care, for the capitation for their care, and not be able, and knowing that they will not be able to access the care that they need anymore.
I'm not getting the same, well, not that, but they don't get the same quality of care that they were getting,
Yes.
to be perfectly
Well,
frank.
it would still be difficult because now it requires transportation, it requires finding a pharmacy, and it's difficult enough to figure out the system when you don't have a disadvantage of being older, maybe have some cognitive dysfunction or whatever, and not having others to help you go through this.
And now we're seeing ads. I know I'm not supposed to do this, but we're seeing ads on TV about how they're driving us places. And when I came home, they gave me food, and I'll behave. But I'd like to ask Ms. Kennedy the same question. I'm really 5 weeks. Pramila knows I get very intense, and living with John. Well, first of all, it was his father, but having now been back in the system for 5 weeks, it is so broken. It is so broken. And if you don't have an advocate, you are just, you don't have it. It's a real problem. But Ms. Kennedy, I'd like to pose that same question to you from your experience in the nursing field.
Well, just listening to Dr. Rogers, where they're, given this hype about what they have to offer. And then once they get into it, then they can't navigate it. They're not in the network. I mean, so we see it every day. I work for a huge HMO that has a whole capitation program, right? So once they get those dollars, then it's very hard to navigate. I mean, to even see and get an in-person visit. Everything's by either telephone or, by video. It's very, very difficult to navigate that. So we see that, or you see patients that are underinsured and they're really scared to use their copays because they're extremely high. And so they have to make those choices as to whether or not they put food on the table. The medication is very expensive. So I've even heard of patients that actually, slice their medication so it goes a little bit, longer. And that is really detrimental to their health and well-being. And so they refuse to go to see their primary care physicians until they're extremely ill. So you see it all the time. And it's just so unconscionable that hospitals and insurance companies are making profits instead of putting that money back into patient care. So we do see it all the time. Yeah.
Thank you. And when they're cutting their pills in half, there are pills that shouldn't be cut in half. It becomes
That's
a
correct.
medical danger to them. And
Absolutely.
they're not the more educated. So it's so important. Pramila, your turn. I'm going to get worked up if I keep going.
Oh, thank you, Debbie. I mean, I think it's hard to listen to all of these examples and think about the impact on patient care. And particularly, I know with the ACO REACH program, one of the most egregious things was that people were being signed up without even knowing that they were being signed up. And I think, that has been ended, but the entire program still has major problems, and the whole thing, I think, needs to be rejiggered. We've made some improvements for sure with this administration. I don't want to underplay those, but we still have problems. And so I appreciate the conversation. Don, Dr. Berwick, I want to turn to you because you obviously have run CMS, and I would like to get your recommendations on how we fix the issues of profiteering in Medicare Advantage, including the risk score gaming, because it seems to me as you were describing that, it just was making my hackles stand up, because this is just pure greed and gaming and really robbing taxpayer money for these for-profit companies. So what's your recommendation on how we fix this profiteering in this arena, the risk score game?
I understand Congress may have some other uses for that money than
yeah, quite a few, Don. Quite
$100 billion over 8 years. I've got 5 recommendations. The first, you should stop the bleeding where it is. At least index to the status quo. So stop the bleed by indexing the coding intensity factor, which Congress has mandated, to the traditional Medicare level of coding increase. Track traditional Medicare. Freeze MA patients to the payments to the 2022 level. Enough of this is enough. That's just stopping it. Second, CMS should declare an end to the HCC risk coding system within the next 2 or 3 years. It should substitute risk adjustment based mainly on social and demographic determinants of risk, as Dr. Rogers was talking about. Let's fund equitable health, not corporate profits. The third recommendation is that CMS should level the playing field between MA and ACOs. If CMS and Congress can't do that by constraining MA, then do it by having the same rules for both. Give traditional Medicare beneficiaries the same benefits as MA enrollees. It's unfair the way it is now. Fourth, I do think the ACO program should be fostered into a future, but a future only in which CMS pays providers directly, not through insurers or intermediaries that are owned by private equity firms. Finally, if we're going to try a public option as a way to expand Medicare stepwise to other Americans, do not use Medicare Advantage as the mechanism for a public option. Make a public option actually public, with no toll collecting middleman, built on an ACO provider network might be the best option. In the longer run, of course, Congresswomen, the simplest, straightest answer is the one that this caucus exists to center on: a universal, accountable, equitable, governmental insurance system. One payer, the government, with one unified insurance system accountable to the public. That is, or at least was, Medicare for people over 65. And please note, it's probably the most popular government program in history, for good reason.
Thank you so much, Don. Debbie, I'm going to turn it to you. We have two more questions, one for Egan and one for Ms. Grady. And so do you want to go ahead and ask the next one, and then we'll
Yep.
try to end by 3:35. I know we started a little late.
Thank you. Dr. Boerhaus, it is the most popular program, but it took 25 years for us. It was first introduced in 1940 by someone who may have had a similar last name, but it took 25 years to get that, and it's time. It's time. We got more improvements after that, but it's time. Ms. O'Grady, can you explain how the typical private equity investor strategy is fundamentally at odds with taking care of patients and giving good care for patients, patient care versus profit?
Yeah, thank you for the question. So as I said in my earlier remarks, the private equity firm's singular focus when they buy a company is how to generate as much revenue as possible over a very short period of time, regardless of what industry they're investing in. And so in many cases, that means they're looking to double or triple their money in around 4 to 7 years, which you can imagine in healthcare would be very, very hard to do without finding ways to cut expenses. Making cuts at a healthcare provider can mean cutting staff or hours, replacing licensed staff with cheaper or lower licensed or unlicensed staff, dedicating fewer resources and time to training, or not maintaining facilities. For example, there's one private equity owned safety net hospital we studied in Southern California that had mold growing out of the walls in the nurses' station. And one of two elevators was broken for over a year, but its private equity owners managed to siphon over $600 million in fees and dividends from the hospital chain over the course of its ownership. Return expectations could also lead to upselling products or even incentivizing physicians to perform costly procedures that might not be necessary. So just another example, one private equity owned pediatric dental chain that we studied paid $24 million to settle a federal lawsuit a few years ago that it had performed and billed for medically unnecessary dental care services on children insured by Medicaid, including performing medically unnecessary root canals on babies. There are other tactics, more sort of financial engineering. Private equity business model is famous for using very high levels of debt through things called leverage buyouts. So in a leverage buyout, private equity firm uses debt to acquire a company, but the critical thing to know about it is that the debt is secured by the portfolio company. So the company that it buys, the healthcare provider, not by the private equity firm itself. And that means that the healthcare provider is on the hook if it defaults on that debt. It has to make up all of those monthly interest payments, even if the private equity firm exits, sells the company. The provider has to find a way to pay that money back. And that means that there's less cash available to spend on actually operating, greater incentive for the kinds of profit-seeking behavior that are harmful to patients. And meanwhile, the private equity firm has only invested a small amount of its own money. And that means that it has everything to gain and very little to lose.
It is just stunning to me again, and thank you for lifting up my Healthcare Ownership Transparency Act. At least it's a beginning, but just hearing about performing these practices on babies and all the things that are out there is just horrific. Thank you for that, Ms. O'Grady. Mr. Kemp, Public Citizen recently released a report on private equity investment in nursing homes. Our members have received a copy of this report in their meeting packets, but I just want to ask you to share one of your top findings with our members.
Yeah, thanks so much for that question. And following really sort of the great work by Eileen and others at the Stakeholder Project, it really is concerning, and you can see why we'd need to know who's owning all these things. Both Congress, if you're trying to figure out where to put your family member, and so we really wanted to test the comprehensiveness of the ownership data being published by the federal government. It's something that's based both on requirements that predated the ACA, but that HHS has also enhanced, but without implementing formal regulations. And so our study really took an in-depth look at a particular subset of private equity companies and certain nursing homes. And we found some really concerning things. One, a private equity company that appeared to own more than 130 nursing homes, and another that had nearly 60 didn't appear anywhere in the federal government's ownership database. So you would not be able to connect these things to each other or to the private equity company that owned them if you were just looking at that data. One of those private equity firms had a facility that had been had terminated by Medicare for failing to meet basic safety requirements. And folks on the call will know, that takes a pretty high level of failure and misdeeds to have that termination take place. And so you wouldn't be able to connect that to other ones. So you wouldn't be able to say, oh, this one is connected to a place that failed basic safety requirements. Also, we found that among 13 private equity firms believed to possess substantial holdings in nursing homes, only 7 appeared anywhere in the database. There were also supposed to be diagrams of ownership structures to really allow us to understand sort of how these companies were connected. None of those has been made public, and it's unclear exactly how many had been collected as required. And the Biden administration has really promised to do more on this, to take steps to improve the quality, but there's still some regulations that need to be implemented. And so we just believe comprehensive ownership information is essential for effective oversight, and that families deserve to have that information as they make important decisions. Otherwise, it's impossible to really tell who's undertaking these deeds and which private equity companies are taking advantage of this system. And so, working through Congress, through the administration, we think that all steps need to be taken to implement the required regulations, and to also take action against nursing homes that are failing to meet the standards that they must be meeting. Thanks again.
Thank you so much for highlighting that. And I hope all of our members will read that report. We are at time, and I just wanted to recognize that we had with us Congress members Pingree, Shelley Pingree, Andy Kim, Marie Newman, and Jan Schakowsky I see on as well with us, as well as staff from the office.
And Rashida was on for a while too.
And Rashida Tlaib. And I see that we have staff from the offices of Hank Johnson, Don Beyer, Sarah Jacobs, Sheila Jackson Lee, and Jamal Bowman. I hope I didn't miss anybody, but you see that our members care deeply about this issue, and you all have shed a lot of light on the egregious things that are happening in our broken healthcare system, which we're clearly seeing just continues to prioritize profit over people. As Debbie said, the United States spends more money per capita on healthcare than any other industrialized nation. We waste billions of dollars every year on unnecessary costs, while healthcare industry executives and private equity firms measure success in terms of profits, not patient health. So we are very committed to our cause here. We believe it's past time to remove the profit motive in healthcare and recenter our system on guaranteeing quality care to every American. So Debbie and I are so grateful to all of you for joining us in this discussion, and also in the much bigger, critically urgent fight for Medicare for all.